Okay, just letting everyone in the room. We'll just get started in a moment here. Okay, well, welcome everyone. My name's Corey. I'm within the Centre for Digital Transformation of Health, and welcome to our next Making Digital Health Real, which is our fortnightly series that aims to provide space to discuss emerging research, share insights, and showcase projects, and further the network for those interested in digital health. Before we get started today, I'd like to first acknowledge and pay my respects to the traditional owners of the land on which some of us are presenting from today, which is the Wurundjeri land, the land of the Wurundjeri people of the Kulin Nation. I'd like to pay my respect to elders past, present, and emerging, and extend that respect to any First Nations people who may be here today, and just acknowledge that although we've had challenges earlier this year with relations to Indigenous rights, that this is not just because the voice referendum didn't pass doesn't mean that reconciliation is over, and it's up to us to ensure that we're continuing our constant progress towards reconciliation. With First Nations people in Australia. With that, I'd like to introduce Associate Professor Stephanie Best, who's going to introduce our speaker and also get our session started.
Thanks so much, Corey. And thank you everybody for joining this this next session in the Making Digital Health Real seminar series. It's been a really exciting series so far, and today is going to be no exception. We're really super excited because we're going to be sharing this session today with the Centre for Digital Transformation of Health, but also the Melbourne Implementation Research Group based at the School of Health Sciences at the University of Melbourne. We're super excited that we're going to be talking about organisational readiness today in the context of digital health. And I'd really like to welcome you, whether you're new to this sort of area or whether you're a kind of self-confessed nerd. Everybody, all takers are welcome. And we sort of look forward to hearing from a range of you, hopefully sort of towards the end. We will have time for questions at the end of today's session. We won't have them through the session, but if you want to pop them in the chat, if you don't want to lose them, then please do that. But be thinking about them so that we can be ready and make the best use of our valuable speakers' time. And speaking of which, it's a real great pleasure to be introducing Bryan Weiner today. He's a professor in the departments of global health and health systems at the population health at the University of Washington. Dr. Weiner's research probably needs no introduction to you, but it focuses on the implementation of innovations and evidence-based practices in the healthcare setting. Over the last sort of nearly 30 years, he's examined a really wide range of innovations from quality improvement practices, and it's always great to see that whole mix between quality improvement and implementation research. We want to be looking at how we can be bringing things together. But so from quality improvement to care management practices through to patient safety practices as well as informed evidence-based clinical practices in cancer settings and in cardiovascular disease. His research, as we all know, has advanced implementation science by developing new knowledge around the organisational determinants of effective implementation, and by developing new theories of implementation and improving the state of measurement in the field, which is an area many of us would agree that we need to be growing our focus on. So without any further ado, Bryan, could I hand over to you to take over today's session?
Yes, and a pleasure. Thank you for the invitation to speak with you. I know very little about digital health, but I do want to speak with you about the organizational context in which we implement digital health initiatives, because context matters. So it's sort of a core principle of implementation science. So give me a moment to get myself set up here. Let's see, I need to share my screen. Hopefully you can now see my screen. I My slide deck.
Perfect. Yes,
Very
perfect. Thank
good.
you.
Okay. And I apologize. My dog just wanted to go outside, and she will be wanting to come back inside fairly shortly. So I will have to get up for a moment from my seat and do that. It shouldn't be much of an interruption. But again, thank you for the invitation to speak with you. What I'd like to do is just talk a little bit about preparing for implementation, and particularly to focus on organizational assessment and organizational readiness. In this talk, I'm going to cover a few topics. First, I'm going to discuss what organizational assessment is, why one might do it, what frameworks one might use to guide it. And then I'm going to focus on two features of organizations that significantly influence the success or failure of implementation efforts. Those features are organizational readiness for change and implementation climate. And for each feature, I will discuss what it is, explain why it's important, discuss what one could do to create it or enhance it, and highlight some methods and measures for assessing it. Before I get started, though, let me see how easy this would be to do by chat. To pull this up. How many of you have actually been in a well-run, high-functioning health facility? I'm not sure if I can see the hands here, but maybe somebody could raise hands or put in the chat. Actually, and if you have, what are some of the features that have differentiated or distinguished sort of a high-functioning, well-run health facility from your average or everyday sort of health facility? And I do have the chat open, so if you could just put in some comments there. Primary and acute care are integrated. Okay, the way in which care is organized and coordinated. Patients have access to their data. Thank you. Culture of quality improvement, effective communication among all the teams. Yes. And there's the dog. Hold on one moment. Clear pathways. Okay, adequate resources and engaged leadership. Data is real time. Goals and objectives are clear. Fantastic. I imagine we could probably come up with some additional ones. But what this discussion, this brief chat has sort of demonstrated, I think, is that the organizational context matters. That is, that the organizational context in which health services are delivered makes a difference. And so if it makes a sense that if you are going to implement a new program or a new service, that you should conduct an organizational assessment before you do so, and to take steps to ensure that the organizational context is as supportive as possible for successful implementation. So what is organizational assessment? Well, generally speaking, organizational assessment is a process for obtaining valid information about the performance of an organization and the factors that affect performance. And within implementation science, my field of study, the focus is on the organizational factors that influence the adoption, the implementation, and the sustainment of innovations and evidence-based interventions. So why would one want to do an organizational assessment? Well, implementation often takes place in organizations by members of organizations. And so organizational features would play a very significant role in determining the success or the failure of implementation efforts. Of course, there's a broader purpose. Sometimes we simply want to improve the performance of health facilities or schools or agencies or other organizations that are involved in the delivery of health services. But here we're going to focus on the more narrow purpose of organizational assessment for increasing the success of implementation. Let me just back up for a moment and set the stage for organizational assessment. Here's what we know. If you want to attain socially significant outcomes of some type, like improved population health, you need three things. You need proven health interventions, that's the what. You need implementation strategies, that is the how, and you need supporting and enabling context, which would include who and where and so forth. And the who and the where would include things like the characteristics of the individuals that are doing the implementation, their knowledge, their skills, their beliefs, their motivation. It would also include what we would call the inner context, the local organizational context, effective leadership, engagement, available resources, organizational capabilities. You'd also want a supportive and enabling outer context as well, a really deep understanding of patients' needs and resources, and supporting and enabling external policies and incentives. So you really need all three of these pieces. It's not enough to have proven health interventions. You need good implementation, you need good strategies for that, and the context also needs to be supportive. I like to use a gardening analogy. I am still a novice gardener, as this is only my third or fourth year growing vegetables in my home garden here. And I have learned that it is not enough. It's very important when you go to the nursery to pick out good starter plants. I've not had much success with seeds so far, and that to really take good care to pick really good starter plants, making sure that they look healthy, they aren't dried out, and so forth when you're at the nursery. But you also need not just really good starter plants, you need to know a thing or two about gardening. You need to know when to plant, how much to plant, what to plant at different times, how deeply to plant them, how much to space them apart, how much water they need, and so forth, and making sure that the soil is fertilized and so forth. But you also need that supporting and enabling context, as I've just mentioned. You need to make sure that that garden is well positioned to get the right amount of sun, and has good drainage as well as good exposure to rainfall and precipitation, whereas an in-ground irrigation system to provide the necessary water. And that garden needs to be fertilized, and the soil needs to be treated every once in a while to make sure that you still have a productive garden. So you really need all three of those components. And if any one of them is underdeveloped or missing, you're not likely to achieve those socially significant outcomes that you're looking for, or in my case, a good produce from my garden. So before we proceed further, let me also just clarify some terms that I'm going to use. So implementation science is fundamentally concerned with identifying effective strategies or methods or approaches for implementing evidence-based interventions. What do I mean by implementation strategies and evidence-based interventions, or EBIs? Well, implementation strategies are the actions that we can take to enhance the adoption, the implementation, and the sustainability of evidence-based interventions. And evidence-based interventions are things like programs, practices, pills, principles, products, policies, and so forth that have demonstrated evidence to improve health behaviors or health outcomes or health-related environments. So EBIs are the what we seek to implement, and implementation strategies are the how we seek to get those evidence-based interventions into practice in clinical settings or in community settings. And this distinction between what and how is quite useful for distinguishing implementation strategies from evidence-based interventions, and in a sense also helps us understand sort of where implementation science picks up. It picks up where intervention science leaves off. So once we have evidence that a particular innovation or practice does have desirable or produces desirable health outcomes or health behaviors and so forth, our attention naturally shifts from what we should be doing to how do we get that implemented well and integrated into routine care and routine delivery. So coming back now to organizational assessment, why do we do organizational assessment, especially in the context of implementation? Well, three reasons. First, we do it to prepare for implementation. As a formative research tool, organizational assessment can help us identify the drivers of the know-do gap, the gap between what we know and what we do, that often operates in organizational settings like health facilities. So if healthcare providers are not providing guideline concordant care, for example, why is that the case? Are they unfamiliar with the guidelines? Do they find the guidelines unacceptable? Do they forget to use them when they're busy taking care of patients? Do they think they're following the guidelines more often than they really are? Organizational assessment can help shed light on the factors that facilitate or inhibit the delivery or the use of evidence-based interventions in practice settings, including digital health tools. Second reason would be to plan for implementation. Organizational assessment is also useful for guiding the selection of implementation strategies. Implementation is more likely to be successful when the strategies for putting an evidence-based intervention into practice are well matched with the barriers and the facilitators that are operating in that setting. So if the organizational assessment reveals that healthcare providers are not familiar with the guidelines, then implementation strategies involving education and training are good options. Likewise, if organizational assessment indicates that providers forget about the guidelines when they're busy taking care of patients, then a clinical reminder is likely to work well. So organizational assessment can help us select the right tool, that is the right implementation strategy for the job. And this might seem obvious, but it is surprising how many people favor or choose implementation strategies that do not address the barriers that are operating in that setting. Training, for example, is not likely to be an effective strategy if the problem is forgetfulness in a busy clinical encounter. And a third reason we might do organizational assessment is to monitor and evaluate implementation. So it can be quite useful for investigating why implementation is going well or poorly, why some sites implemented more successfully than others, why some components of the evidence-based intervention were implemented effectively while other components were not. So good reasons for implementation practice, also good reasons for doing organizational assessment and implementation research. So I'm going to introduce a few models for guiding organizational assessment for implementation, but I do want to just issue a quick caution here that these models were developed largely in the United States. And they probably need adaptation for use in low and middle income country contexts, or even other country contexts that differ culturally or have quite different healthcare systems and so forth. Okay, so the first model I just want to briefly introduce to you is one that is specific to implementation science. It's called the PRISM, which stands for a Practical, Robust Implementation and Sustainability Model, PRISM. It is a comprehensive model for translating research into practice. It was developed using concepts from quality improvement, from the chronic care model, the diffusion of innovation theory, as well as REAIM, which is a public health evaluation framework that's quite often used in implementation science. The PRISM describes how a healthcare program or intervention interacts with the recipients and the deliverers to influence program adoption, program implementation, program maintenance, as well as the reach of the program and its effectiveness. It is intended to be practical and prescriptive, so it's a very useful tool for research, but also a useful tool for healthcare decision makers to understand what factors need to be considered and to address those factors, and also how to measure success. What I like about the PRISM is that it identifies key questions that implementers should ask and answer before implementation takes place. That is, before you implement a practice, a program, or a policy. It also offers suggestions, some of them very concrete, some of them more general in nature, for what to do before you implement a practice to maximize your chances of success. Like I said, very practical and prescriptive kind of model. Very useful for practice, but also useful for research. For example, looking at the intervention from the organizational perspective, a key question to ask up front is, no surprise, are key staff ready to conduct or deliver the intervention? So it's easy to ask this question and get the answer wrong if you don't think carefully and inquire deeply about staff readiness. Are some staff ready and others not? In what ways are the staff ready? In what ways are they not ready? And what can be done to increase readiness? And as you can see, the suggestion here is to really consider readiness from multiple stakeholders, not just frontline staff, and certainly not just from top-line managers. So the PRISM questions, this is just one example here, can guide an organizational assessment for implementation. These are the factors that would determine the success or failure of implementation, and simply asking these questions, the questions in the PRISM, is likely to increase your chances of success. So how do you do this assessment using PRISM or any of the other models I'm going to show you here? Well, the answer is any number of ways. You could simply gather a few stakeholders together and discuss, or you could be more systematic about it and use focus groups or questionnaires or observations to inform your assessment. there really isn't one best way. What's more important than how you do the assessment is that you do the assessment and that you do it thoughtfully. And the PRISM offers many assessment questions, each with its own suggested course of action, and these are described in an article which I can pass along after my talk. So the PRISM is a practical and prescriptive model. It offers some great how-to advice. There are other frameworks for implementation science that are useful for research more so than for practice. One such framework is the Consolidated Framework for Implementation Research, or CFIR. The CFIR is an explanatory framework rather than a how-to framework. It identifies a wide range of factors that influence whether implementation succeeds or fails, but it doesn't tell you how to implement the intervention. It's not prescriptive in that sense. Still, you can see from this slide that the CFIR includes many of the same ideas and constructs as the PRISM. The CFIR can be used in formative evaluation, much like the PRISM, to identify upfront barriers that need to be overcome, as well as facilitators that could be drawn upon or strengthened for implementation. It is more often used in a summative evaluation context to explain the variation in implementation success that occurs. It is why implementation maybe went well in some places, some clinics, and maybe not so well in others. The nice thing about the CFIR is that it comes with interview guides, templates, as well as coding manuals and other kinds of rubrics for analyzing qualitative interview data. So it provides sort of a nice turnkey solution for doing organizational assessment. Let me just give you a couple of examples of the CFIR in the global health context, which is certainly the context that I work here. Van Deventer and her colleagues planned to evaluate the effectiveness of 2 strategies for implementing tobacco use treatment guidelines in 26 commune health centers in Vietnam. And prior to implementing the trial, they conducted formative research using the CFIR to, 1, identify factors that might influence guideline implementation, and 2, to inform further modifications to the intervention that might be necessary to sort of translate this model of care delivery from a high-income country context like the United States to the local context of an LMIC, in this case, Vietnam. Through qualitative interviews, they learned that 4 of the 5 CFIR domains were relevant to the analysis. The implementation process domain, not surprisingly, wasn't relevant since this was a formative research study. It was conducted pre-implementation. Potential facilitators of intervention implementation include the relative advantage of the intervention compared to current practice, awareness of the burden of tobacco use in the population. There is a very high smoking rate, tension for change due to the lack of training and the need for skill building and leadership engagement. So staff really saw a need to do something about this problem and to do something differently than what they have been doing, and recognized that they would also need skills, and the leadership of these commune health centers was also quite eager and engaged to help implementation move forward. And then a strong sense of collective efficacy to provide tobacco cessation services to the communities that are served by these health facilities. Let's see, potential barriers included the perception that the intervention was more complex and not necessarily compatible with current workflows, which is very common in health services delivery. Workflows do need to be redesigned to incorporate and integrate an evidence-based practice. It's not currently being done. Staffing historically was designed to address sort of infectious disease prevention and control rather than chronic disease prevention. And then there were also competing priorities that are determined by the Ministry of Health. So a variety of factors in the inner setting, the outer setting, and the characteristics of individuals and so forth, and intervention characteristics that either facilitate or inhibit or might serve as facilitators or inhibitors of implementation. Another example here, so that was a formative use of the consolidated framework, and here's a summative use of it. Sarah Gimbel, my colleague here at University of Washington, used the consolidated framework, or CFR, to evaluate the implementation of the systems analysis and improvement approach in an effort to strengthen the prevention of mother-to-child transmission of HIV programs in 3 African countries. And SIA is a package of systems engineering tools and quality improvement approaches that Sarah Gimbel and Kinney Shearer and some of my other colleagues here have developed and refined through iterative evaluation and testing. These investigators use the consolidated framework, the CFR, to, one, identify the core and the adaptable components of SIA. What are the pieces of SIA that must be done for this implementation strategy to work, and what can be modified or adapted or potentially not even used and still find some effectiveness for this particular strategy. They also, as a second goal, wanted to explain the heterogeneity in SIA's success between facilities and between countries. So they learned that 2 SIA components of this implementation strategy, that were the 2 components were flow mapping and continuous quality improvement, were core components of SIA in all the settings, whereas the PMTCT, or Prevention of Mother-to-Child Transmission Cascade Analysis tool, another tool that they developed, was a core component of SIA in high HIV prevalence settings, but not a core component of SIA in lower HIV prevalence settings. Moreover, they learned that 5 of the consolidated, 5 of the CFR constructs help really distinguish strongly between high and low performers, or in this case, between settings that had high degrees of implementation success and others that had less success. The 2 constructs in particular from the inter-setting domain that were important, specifically the availability of resources and networks and communication. The other 3 constructs were in the implementation process domain. How you implement something, the process itself is also important. Those constructs were the use of external change agents, the process of executing the implementation plan, and the processes of reflecting and evaluating in a learning sort of cycle from the implementation experience. So I'd like to sort of drill down in the next portion of my prepared talk here, drill down into the inter-setting domain, that sort of organizational context area of the consolidated framework, and focus on 2 constructs: implementation climate and readiness for implementation. These are 2 features of organizations that influence implementation success or failure. So what is implementation climate? Well, very briefly, implementation climate refers to targeted employees' shared perceptions of the extent to which the use of a specific innovation is expected, supported, and rewarded. And by targeted employees, I mean those people in the organization that are responsible for implementing or delivering or using the evidence-based intervention. So colloquially, let me break this down. Colloquially, in an organization's implementation climate offers targeted employees, that is the implementers, answers to the following questions. Are we expected to do this? How clearly and how strongly is this expectation communicated? Can we in fact do this? Do we have the knowledge, the skills, the resources, the information, the time, and so forth to actually implement this well? And thirdly, if we do this, what will happen? Will good things happen? And in particular, will I benefit in any way? So I'm a big fan of legal thrillers. So if expected and supported and rewarded seem too abstract or too academic for you, you can think about implementation climate in terms of means, motives, and opportunities. And I want to emphasize employees' shared perceptions here, because often implementation is a team sport. It's not enough if some people feel that the delivery of the evidence-based intervention or the use of that intervention is expected, supported, and rewarded, while others don't share that. When that happens, you get limited or sporadic or uneven sort of use or delivery of that evidence-based intervention. If you want consistent, high quality use or delivery of an evidence-based intervention, you want all of the targeted employees, all of those that are expected to use that or deliver that intervention, to feel a strong sense that intervention use or delivery is expected, supported, and rewarded. Now, implementation is not always a team sport. There are some interventions that individual healthcare providers can adopt and implement on their own with relatively little support, and to see some benefits for their patients regardless of what is happening in the next exam room. So prescriptions, medications are a good example of that. But the really more interesting and more complicated sorts of interventions are often require collective and coordinated behavior change. And not just among the providers, but you also need to get IT and HR and managers, and even sometimes the custodial staff have to be involved for implementation to go well. We think about antibiotic, you think about the prevention of nosocomial infections or something along those lines, and to increase antibiotic stewardship. It's a team sport. And when implementation is a team sport, implementation climate is absolutely critical. So implementation climate theory posits that when implementation climate is strong, that is when all of those people who are expected to deliver or use that intervention or innovation feel that doing so is expected, supported, and rewarded, you get effective implementation, which we can define as consistent, high quality intervention delivery or use. When EBIs, when evidence-based interventions are effectively implemented, you obtain expected benefits or positive outcomes. This is depicted in the figure here by the link between implementation effectiveness and innovation effectiveness. The language here is a little different because the theory was developed to explain the implementation of interventions or new practices rather than the implementation intervention, to explain the implementation of innovations or other new practices rather than the implementation of evidence-based interventions or evidence-based practices. The theory actually emerges from the field of the study of manufacturing, but it works just as well when it comes to evidence-based interventions. Yeah. So how do you create a positive and strong implementation climate? Well, you do so by making use of what I've called, or what's called in this theory, implementation policies and procedures, or policies and practices that are designed to enhance those targeted employees' means, motives, and opportunity, that are designed to create a strong shared sense of expectation, a strong shared sense of support, and a strong shared sense of reward or of recognition for evidence-based intervention use and delivery. So I'm using the term implementation policies and practices here as sort of a shorthand phrase to refer to a wide range of plans and practices and structures and strategies that an organization can employ to support intervention, delivery, and use. Organizations can make use of a rich inventory of implementation policies and practices, including things like training and technical support, rewards and incentives, persuasive communication, end user participation in decision-making, workflow changes, workload changes, alterations in staffing levels or staffing mix, new reporting relationships and or documentation requirements, monitoring or enforcement of policies and procedures. The list goes on and on. For example, an organization can strengthen the implementation climate by making sure that targeted employees, those that are going to be doing the implementation, have easy access to high quality training, technical assistance, and documentation, all of which is going to enhance their knowledge and skills. Likewise, organizations can engage employees in decision-making about intervention implementation. They can provide incentives for intervention use and delivery. They can provide feedback. And those incentives don't have to be monetary. In fact, they can be social, and they can be quite powerful. They can also provide feedback on intervention, delivery, or use. All of these are going to enhance the motivation of those targeted employees. And then finally, organizations can make that intervention easily accessible, easy to use. They could give targeted employees the time to learn how to deliver this intervention well and to use it well. They could redesign work processes to help support intervention, delivery, use, all of which is going to sort of increase opportunities for intervention, use, or delivery, and or remove barriers for doing that. So note that implementation climate is strongest when employees have the means, the motives, and the opportunity to deliver or use interventions. You need all three of those components. If you have the motives but not the means, you don't get good results. So it's important for to make sure that your implementation policies and practices are really creating a strong sense of expectation, a strong sense of support, and a strong sense of reward, recognizing that the reward is not necessarily a financial incentive or payment. It can be social recognition, it could be the intrinsic satisfaction that comes, it can be patient feedback, it can be any number of things that make it rewarding or at least remove any disincentives or perverse incentives that might be operating in the setting. So does implementation climate matter? Well, although a few studies have investigated this question, relatively few studies have done so, we do have some evidence that it matters. So Kia Turner, a colleague of mine who's at the University of North Carolina, Chapel Hill, she tested this theory in the context of a community pharmacy medication management program. And they observed that implementation climate was associated with implementation effectiveness, good implementation, and further that innovation values fit moderated this association, which is a construct I haven't really described a whole lot of, but just to say very briefly that the extent to which people feel that uses of this innovation helps to fulfill their values, whatever those values are, the better the fit between the innovation and people's values is a moderating condition of this relationship between implementation climate and implementation effectiveness. And this is precisely what the theory predicts. In another study, Nate Williams and his colleagues, some other colleagues of mine here in the US, examined the independent and joint influence of implementation climate and organizational climate on clinicians' use of evidence-based psychotherapy techniques. They observed that organizational climate, which is sort of broader construct than implementation climate. Implementation climate is really specific to the innovation, the extent to which innovation use is expected, supported, and rewarded, whereas organizational climate sort of describes what it's like to be here. Whether this is a warm and fuzzy place or a competitive place, a very formal bureaucratic organization, or very loose, informal, familial kinds of environment. Sort of what is the organizational climate like here? They observed that organizational climate moderated the association between implementation climate and implementation effectiveness. Specifically, when the organizational climate was supportive, implementation climate was positively associated with implementation effectiveness. And when organizational climate was not supportive, implementation climate was not associated with implementation effectiveness. And I like to think about it this way. You can create a really strong climate for implementation using really powerful implementation policies and practices to create a strong sense that people are expected, supported, and rewarded to use this innovation. But if that organizational climate is really poor, morale stinks, there have been rounds of layoffs and budget cuts, and everybody is tired and sick and don't want to be there, and they can't get along, or there's just a lot of conflict over contract negotiations or whatever is going on. If that organizational climate is also not positive, it's very difficult for that implementation climate to have the kind of effect you're looking for. Those policies and practices are going to be considered in that context of poor organizational climate, and probably not going to be as effective in creating that shared sense of expectation, support, and rewards. So why aren't there more studies of implementation climate? Well, because the theory is kind of difficult to test. One needs a large sample of organizations implementing the same innovation or similar innovations. One also needs to collect, because it's an organizational level construct, you need a lot of organizations all implementing roughly the same thing. You also need to collect implementation climate perceptions from many organizational members, not just one or two. And ideally, you'd want sort of longitudinal data to test whether the changes in implementation climate are related to changes in innovation use. And that's a pretty tall order from a research perspective. Still, it's nice to see that we do have some studies showing that there are significant associations and that those match what the theory predicts. So let me switch now to talking about organizational readiness for change. And it almost goes without saying that implementation tends to sputter or stall or just fail altogether when targeted employees are not ready for implementation. What do I mean by ready? Well, in conversational English, to be ready is to be prepared. If I ask you if dinner's ready, I'm asking you if dinner's prepared. If I ask you, are you ready to walk out the door because we are late for the party, I'm asking, are you prepared to walk out of the door right now? All right, so you can think about the closest synonym for ready in English, in ordinary conversational English, is prepared. So by extension, organizational readiness refers to the extent to which targeted employees are prepared psychologically and behaviorally to take action to implement an evidence-based intervention. And note, I said psychologically and behaviorally prepared. So in conversational English, when we ask, are you prepared? We want to know, are you willing and able? Likewise, organizational readiness has both a motivational component and a capability component. So it has both the willingness and the able. There's a motivation and capability. So put in the formal language of theory, we can say that organizational readiness has two dimensions. The first dimension is change commitment, which I define as targeted employees' shared resolve to pursue the courses of action involved in implementation. And the second dimension is change efficacy, which I define as targeted employees' shared beliefs in their collective capabilities to organize and execute the courses of action that are involved in implementation. Note again, I emphasize shared commitment and shared or collective efficacy because implementation is often a team sport. Often implementation involves collective coordinated action among many individuals, each contributing something to that implementation effort. In such cases, it's not enough if some targeted employees are ready while others are not. When that happens, implementation suffers. So when organizational readiness is high, targeted employees are more likely to initiate implementation and to do so on time or on schedule. They're more likely to persist in the face of obstacles or setbacks, which inevitably occur. And when that change commitment is really high, is when it's based on affective commitment, employees will be willing to go the extra mile to support implementation. And all this sort of change-related effort helps to lead to more successful implementation. So how do you create organizational readiness for change? Well, the theory offers two suggestions. The first is to increase change valence, or simply the extent to which targeted employees feel that the change is needed, important, beneficial, and worthwhile. The more the more employees value that change, the more committed they will be to implement it. The second is to influence targeted employees' informational assessment of the task demands, the resources available, and situational factors. So in formulating when people formulate their change efficacy judgments, their sense of whether or not their level of confidence that collectively they can implement this intervention well. Organizational members sort of acquire and then they share and assess information that bears on sort of three questions. Number one, do we know what it will take to implement this change effectively? Number two, do we have the resources to implement this change effectively? And number three, can we implement this change effectively given the current situation we face, or the situation we currently face? So organizational leaders can shape directly people's perceptions of task demands, resource availability, and situational factors. They can shape those factors directly. They can make more resources available. They can make the situation more favorable. They can also shape employees' perceptions of these factors as well through things like persuasive communication and so forth. just take one more step, switch tacks a little bit here and just talk about how one might assess organizational readiness for change. That theory that I just laid out for what organizational change is, in what ways it matters or what outcomes it can produce, and how one might create it, help to inform the development of a brief, reliable, and valid measure of organizational readiness for implementation that I developed in concert with some of my colleagues at the University of North Carolina before I moved to the University of Washington, and described in this particular paper. I don't have much time to talk about, I don't want to get into the details about the measure development and testing process. Really well described in that study. We used a very systematic process to develop the measure and to evaluate its psychometric properties through a series of studies, both controlled studies in the sort of a lab context as well as field studies that were more observational in nature. I just want to mention a few features of this measure called the ORC, Organizational Readiness for Implementing Change, that I think are important here. As you can see, it has many of the psychometric properties or properties of measurement of measures that we researchers care a great deal about. Content validity, some reliability, so it's very consistent, structural validity, structural invariance, and some of these other characteristics, which I'd be happy to describe in more detail for those of you who are interested in it. But it also has several other features that I think are very attractive. One is it focuses on a very specific change, so you can tailor it, so you can find out ready to implement X, whether it's intervention X or intervention Y or program Z or whatever it is. You can focus this on a specific change, so it's not gauging sort of what the organizational context is like, but really gauging organizational readiness for implementing this particular intervention, which is really important because the very same organization can be ready to implement one innovation and not ready or to implement another innovation, a different innovation. Second, it focuses on very common implementation tasks, but we also have an item bank that allows you to tailor the instrument a little bit in case a key implementation task in your context isn't represented among the items set that I'm going to show you in a minute. It directly measures readiness as opposed to its antecedents, so it doesn't tell you, whether people perceive a high need for change or perceive relative advantage of this particular innovation, or other factors that might influence their change valence, or how much they value the change. It measures readiness directly, so it focuses on change commitment and change efficacy. The items are group referenced, so it really focuses on we rather than I, which is, again, as I mentioned earlier, important in the context where implementation is a team sport. And very importantly, it is short in length. And there are additional items available for people who are more interested in lengthening the instrument. This is just a quick look at what those items look like. The items in red are the items, I think there are 10 items here, might be 12. Not really good at counting on the fly here. We have two different versions of this measure. The red items tap or assess change commitment, and the items in black font tap change efficacy. So does organizational change matter? Well, again, it's not something that has been studied a great deal. The outcomes or consequences of organizational readiness have not undergone a lot of empirical study, even though intuitively it makes a lot of sense. But here are two recent studies, both of which use the ORC. Sarah Soling and her colleagues observed that organizational readiness for change had both direct and indirect effects on physicians' behavioral intentions to adopt a digital intervention, or digital innovation, I should say, for polypharmacy management. So I managed to get a little digital health in here. Forgive me, that may be the one and only reference to digital health that you're going to get. It's just not my area of expertise. Interesting that it had both direct and indirect effects on behavioral intentions. And in another cross-sectional study, Jennifer Lewis observed that facility level organizational readiness to implement change was associated with lung cancer screening utilization. For every 1 point increase in organizational readiness for change and change valence, that construct that I mentioned earlier, how much people value the change, there was an associated 8.4 percentage point increase in utilization of lung cancer screening. at the, measured at the facility level in terms of screening rates. So why aren't there more studies of organizational readiness for change and its effects on implementation? Well, like I said before, with respect to implementation climate, this theory is difficult to test. These are organizational level constructs, so you need a lot of organizations, a large sample of organizations, all implementing roughly the same intervention or innovation, roughly at the same time. You also need to collect a lot of information from many different targeted employees in that organization, not just a few. And ideally, you'd want to have longitudinal data to test whether these changes in changes in organizational readiness also lead to changes in implementation or more effective implementation. And you need all those things to sort of line up, all those organizations prepared, or I shouldn't say prepared because that's the wrong term, organizations that are planning to implement roughly the same innovation at roughly the same time. And you need them to all hold off until you get your grant funded so that you can actually do the research. So a pretty tall order to do. But it is still encouraging to see that we do have a small but hopefully growing base of evidence that to back up our intuition that that organizational readiness matters. I just want to close, I think, with the repeat of my cautionary statement earlier. The theory of organizational readiness for implementation or organizational readiness for change that I mentioned is also developed in the US context and largely draws upon social and psychological theories that were developed in the US context. Cultural context is quite different than the cultural context of other countries, especially other lower and middle income countries. And much of it draws upon research and theory developed out of the study of business organizations. And again, healthcare delivery is not quite the same here. So I think organizational readiness might have more or may have more or less importance in different country contexts and may have different meanings in other country contexts, and therefore might need to be measured using different kinds of items than those that I've showed you. So let me just conclude here with a few high-level takeaways. First, I want to emphasize that organizational assessment is really useful for understanding and influencing the context of implementation. Context matters, useful for both research and for practice. Identifying the factors that explain variation in implementation success is important. Identifying the factors that need to be modified to support implementation, also important. Organizational models are organizational in focus. It's important not, maybe this is a takeaway I should say a little bit more. I talked about organizational readiness for change and implementation climate, both of which are constructs in that inner setting in the consolidated framework. So intra-organizational factors, right? But organizations don't exist in a vacuum. And in health systems, especially in lower middle income countries that are organized vertically with ministries of health, which we don't have in the United States, that outer context, so to speak, or the extra-organizational or inter-organizational context, or the policy context, or the community context, may in fact be more important, maybe just as important, maybe even more important for how implementation goes in an organization than these sort of intra-organizational factors. But again, United States, we have a very decentralized healthcare system, and I use the term system very loosely here and put it in quotation marks, scare quotes. And we don't have a Ministry of Health. We have a highly individualistic culture. We have a culture that is anti-authoritarian. We value and respect the mavericks, the cowboys, and so forth. So respect for authority, respect for hierarchy, the formality with which we conduct things. All of those things are cultural attributes that part of U.S. culture that influence how healthcare is organized and delivered, and therefore are going to be factors that influence our both organizational behavior as well as our theories about organizational behavior, how people behave here. So I do caution people when they want to take these theories and this body of research and say apply it in other country contexts that have a more communal organizational, communal set of values or collectivist set of orientation, or have health systems that are organized quite differently than they are in the United States. So with those caveats, though, let me just say, I think that organizational models that I have presented, they do point to a common and finite set of factors that influence organization. There are a lot of organizational models out there, organizational assessment models, but there's a lot of overlap among them. I just presented 2, and you could already see some overlap there. There are more. The third point I want to leave you with is that organizational assessment can be conducted qualitatively or quantitatively. The assessment can be done informally, it can be done formally, it can be done with interviews and focus groups and observations. It can also be done with surveys and quantitative measures, although we don't have a lot of reliable, valid, and practical measures of key features in the organization. I think what's more important than how you do the organizational assessment is that you do an organizational assessment, especially prospectively, before implementation begins, so that you can select the implementation strategies that are going to be necessary to support implementation, and you can take other steps to ensure that organizational context is supportive of implementation as well, which, if you can recall from my slide with the gardening analogy, are the 2 other components that you need to make sure that implementation of interventions works well. Because an intervention, no matter how effective, is not going to produce the results you're looking for if it is implemented poorly. And with that, I will finish my prepared remarks and be happy to take any questions or engage in conversation.
Bryan, thank you very much. That was a fantastic whistle-stop tour over a massive range of research that you've been doing in this field. So thank you very much for sharing all your thoughts around this. We don't have a huge amount of time left.
Sorry about that.
No, there was too much to share. Please don't apologise. I feel honor bound, but I need to ask, there's a question in the chat at the moment that I just want to share, which I must ask before I ask my own questions, and I have a whole list of them, of course, is, and Richard, thank you very much for popping this in the chat. Richard asked a question and he said, what about language and literacy and power issues? And I'm assuming, Richard, that you're talking here around in the context of assessing organizational readiness. I wonder what your thoughts are around that, Bryan.
Yes. So again, I think the lack of attention to power in the 2 theories that I just mentioned is sort of reflective of the context in which these theories originated. So we have very powerful health professions here in the United States, and they are often not employees of the organization, of the health services organizations in which they work. And those health professions guard their scopes of practice with a great deal of vigor. And so I think the power is incredibly important, and that I think what's neglected in a lot of our implementation science theories is the political nature of implementation. The politics of implementation, I think, is often understudied. We find other euphemistic terms for constructs to sort of hint at some power issues that don't really get at the power, don't use the word power directly. I think that's maybe also perhaps a cultural reticence to sort of acknowledge power differences, because we pretend that we are an egalitarian culture and value equality and individualism a great deal. And so this attention to power, I think, is neglected. I do think they are really important that go on here. One way in which it shows up in the theories that I proposed is end user or targeted employees participation, frontline staff, I'll use the term instead, frontline staff involvement in decision making, in the decision about whether or not to adopt an evidence-based intervention. So the initial decisions around adoption, for example, as well as participation in decision making and through quality improvement approaches, participation in the actual implementation activities to guide sort of how that's going to go. That's one way in which I think power issues can be mitigated, and organizations can really benefit from the practical wisdom and knowledge and experience that frontline staff, clinical or non-clinical staff, have about what it's going to take to implement this intervention well.
Yeah. I think the beauty of some of the frameworks that you've been sharing today around how they make things quite explicit. And I wonder whether there's more work that can be done that we can maybe start to make some of these power issues more explicit, and because as you say, there's a lot of those things that we euphemistically kind of refer to, and a lot of us are very familiar with, but we don't necessarily sort of put our finger on. With that, it's 11 o'clock on the nose here in Melbourne, so I'm going to close today's session. I just want to say a huge thanks to Bryan for giving us his time, and thank you to the Centre for Digital Health Transformation for organising this whole seminar series. There'll be more seminar sessions coming up soon, so please keep an eye out for those. Thank you very much for joining us, everybody. Toodaloo.
Okay.
Thank you so much.